Welcome to Strategies to Reduce Health Disparities and Improve Outcomes in Breast and Prostate Cancer. Today we'll be discussing prostate cancer in Black men. How can we do better? I'm Dr. Samuel Washington, Assistant Professor, Urologic Oncologist at UCSF. I'm partnered today with Dr. Sandy Srinivas, a Professor in Medicine, Clinical Research Leader at GU Oncology at Stanford University. Thanks for taking the time for us to have this discussion. Now, for this session, there are a few learning objectives. The learning objectives for this session include identifying variables contributing to health disparities in the management of prostate cancer in Black men, and increasing confidence in selecting appropriate therapy based on prior evidence and individual patient characteristics and needs. First, we'll discuss variables contributing to disparities in the management of prostate cancer in Black men. Within the United States, this year alone, there's over 288,000 new diagnoses of prostate cancer estimated to occur. For Black men, this continues to represent a disproportionate burden of disease, accounting for 37% of all cancer diagnoses, as well as nearly 42,000 new diagnoses in last year. It remains the second most common cause of cancer deaths. 17% of all cancer deaths are Black men, and last year alone representing over 6,000 deaths due to prostate cancer. Over time, we've seen that death rates attributable to prostate cancer have decreased for everyone, but we see that that benefit has not been the same across different groups. We know that African American men continue to have a higher rate of death from prostate cancer compared to white counterparts for multiple different reasons. Decreased rates of screening, earlier onset of disease leading to later stage of disease at diagnosis, as well as questions regarding the quality of care that's being provided.
Sam, I just wanted to talk a little bit about this issue of screening. It's been with the PSA not being used for screening, we do see a lot more patients with metastatic disease and more advanced disease. Do you think this is more specific to Black men where screening has been a big factor?
I think it's a great question. I think it's exacerbated existing disparities. So prior to changes in screening patterns, we knew that African American men were not screened as often or as frequently as other groups. Now, if we decrease screening across the board, we're going to see even greater impact in terms of disparities of care within Black men. Now, how does this present or manifest in the real world? One example for me as a provider is I was recently presented with an African American patient, 67 years old, who had a known family history, a twin diagnosed with prostate cancer. He, over several months, had been presenting with back pain to the emergency room, to his primary care doctor. And they often sought of managing this back pain as musculoskeletal or concerns that it may be a manifestation of other issues. It wasn't until he saw me that we started to get the PSA, and unfortunately we diagnosed him with metastatic disease. But this is a constant reminder and a key example of how earlier screening, particularly in someone who had known risk factors, African American race, positive family history, a twin, and a concerning set of symptoms which require a broader differential, could have potentially benefited this man if we had been able to diagnose him sooner.
So, what drives these differences?
These differences in outcomes and survival that we're seeing are multifactorial. There's a lot of different factors that we're looking at, but thankfully over the last few years, we've started to consider how social determinants of health are impacting Black men and other groups. We know that even within a group of Black men, social determinants of health and their impact on the individual represents a contributing factor to changes or differences in prostate cancer-specific mortality, as well as overall survival. We know that these social factors also have an impact on biology and response. Studies have shown greater neighborhood deprivation is associated with a pro-inflammatory state, and we know that it's dose-dependent, so greater social stressors elicits a greater biologic response. The 2023 NCCN prostate cancer early detection guidelines have started to incorporate this as well. When we discuss baseline evaluations and risk assessments, a Black or African American identity remains a risk factor and is a common cause or reason for earlier discussions of screening. Within the footnotes for these guidelines as well, they discuss that social determinants of health, poor access to screening, and biology are all contributing to the greater risk that we're observing within Black men. And within the guidelines, it's noted that this is attributable to greater risk of developing preclinical prostate cancer, a greater likelihood of this preclinical cancer spreading, a lack of access to care, and other social risk factors resulting from the impact of social determinants of health.
So do you have an age cutoff for when you recommend screening for Black men? Is there a difference compared to the general patient population?
Now, because of these contributing factors and the overall disparity that we're seeing, there has been a discussion to start decision making at an earlier age, at age 40 for Black men. But we know that there is not really a consensus across all the different associations within urology. There's also been a discussion of should we be screening more regularly within this group compared to others. Discussion that has moved towards screening annually rather than every other year within this population.
That's a really interesting point. I know we have stressed age cutoff to do it more at an earlier age, at age 40, but it makes total sense that you would want to do that not just earlier, but also more frequently as well.
Totally agree. And this is really because over the decades we've seen disparities in care and outcomes persist for Black men, particularly in the space of prostate cancer. But it's hard to know what to do because the current state of our knowledge, there's just too little data. We know there are too few Black men enrolled or involved within research, and particularly clinical trials, to truly know, do Black men respond differently to these newer drugs? And then how do we reduce disparities in care and treatment for Black men? That leads us to the next question. What do we know about clinical trials and Black men within them that can help inform treatment moving forward?
I think that's a great question, Sam, and it is somewhat frustrating because as we think about what is the appropriate therapy for a patient sitting in front of us in clinic, we typically resort to guidelines and we go back to large clinical trials that have given us the outcomes. That's level 1 evidence, and it's on those basis that we recommend therapy to our patients. The problem with many of our trials that have occurred to date, especially if